Good morning, good afternoon, and good evening, esteemed professors, doctors, guests, colleagues, and participants from all over the world. Welcome to DSD webinar, Improving DSD Care in Resource-Limited Settings, Early Recognition and Practical Management, an international webinar conducted by Global Pediatric Endocrinology and Diabetes. Before beginning today's webinar, we would like to inform you of the rundown of this webinar. We will begin with a welcoming address from the Vice President of GPED. This will then be followed by our first presentation entitled Approach to Atypical Genitalia in Resource-Limited Settings by Dr. Somaya Aftab. The second presentation, Red Flags in DSD, How to Estimate Malignancy Risk, will be delivered by Professor Martin Cools. For today's webinar, it will be concluded with a discussion session led by our esteemed moderator, Dr. Agustini Utari. For the smooth running of today's event, kindly pay attention to the following rules and regulations. Participants are encouraged to have their videos turned on throughout the webinar. Participants should also keep their microphones off unless permitted by the moderators. And to obtain a certificate of attendance, participants are required to attend the entire duration of the webinar and fill in a feedback form. This webinar also utilizes Zoom closed captions. The Zoom closed caption is a function where you can see live captions and have it translated to your preferred language. In the meetings toolbar, next to show captions, click the up arrow icon and then select your speaking language and select your translation language. On the pop-up, confirm the language you want to set as the spoken language and then click save. To officially open our webinar, we will now respectfully invite our first speaker to deliver the opening address, she will also be the moderator of this webinar. Without further ado, to Dr. Agustini Otari, the Vice President of the GPED, the time and screen is yours.
Thank you, Arnita, for the nice introduction. Good afternoon, good evening, and good morning to everyone joining us from around the world. On behalf of the Global Pediatric Endocrinology and Diabetes, or GPED, it is my great pleasure to welcome you to today's webinar, Improving the SD Care in Resource-Limited Setting, Early Recognition and Practical Management. Thank you for taking the time to join us. It is truly encouraging to see participants from so many different countries united by a common goal to improve the care of children and adolescents with the differences of sex development, or DSD. We are happy to share that we have received 575 registrations from 79 countries. Differences of sex development represent one of the most challenging areas in pediatric endocrinology. The diagnosis and management often require timely clinical recognition, appropriate investigation, multidisciplinary collaboration, and sensitive communication with a patient and their families. These challenges become even greater in resource-limited setting, where access to specialized expertise, diagnostic facilities, and long-term multidisciplinary care may be limited. Yet, regardless of where we practice, every child deserves accurate diagnosis, compassionate care, and the opportunity for the best possible health outcome. By sharing practical experience, evidence-based approach, and lessons learned across different healthcare systems, we can help bridge this gap and strengthen the SD care globally. Today's webinar together two outstanding international experts who will share their knowledge and experience. Our first speaker, Dr. Somaya Aftab from the Children's Hospital Lahore, Pakistan, will present approach to atypical genitalia in resource-limited setting, providing practical strategies for early recognition and initial management where resources may be constrained. Our second speaker, Professor Martin Cools from Ghent University Hospital, Belgium, We'll discuss red flag in this DSD, how to estimate malignancy risk, highlighting important clinical consideration in assessing gonadal tumor risk and supporting appropriate decision making. We hope this webinar will be interactive and engaging. We encourage you to participate actively by submitting your question through the Q&A or chat function throughout the session. We will have a dedicated discussion period following the presentation. Without further ado, let's us begin today's webinar. Unfortunately, due to unforeseeable circumstances, Dr. Sawa Musa is unable to join us as moderator, and I will moderate today's webinar. To begin our program, it is my pleasure to introduce our first speaker, Dr. Somaya Aftab from the Children's Hospital Lahore, Pakistan, who will be presenting a topic approach to atypical genitalia in resource-limited setting. Dr. Somaya is a head of pediatric endocrinology and diabetes at the University of Child Health Science and the Children's Hospital Lahore, Pakistan. She founded Pakistan's first structured type 1 diabetes training program, helpline, and peer support group. With more than 50 years experience and over 40 publications, she contributes internationally through SP, ISPAT, GPED, and SPED-P, advancing equitable pediatric endocrine care in low and middle income countries. So, Dr. Somaya, time is yours.
Thank you so much, Agustini, for such a kind introduction. I'm just going to share my slide. Okay. Can you see my slide?
Yes, but it's, yeah, okay.
Okay, is it okay? Perfect. So, Agustini, thank you so much for this kind introduction. And I'm truly grateful for GPED for making me a part for this wonderful webinar. And I believe that in next 25 minutes, we will be able to learn together that how we can approach a baby who was born with atypical genitals. I have nothing to declare, but I can assure you that all the pictures and images that I'm going to share in my presentation, they were shared after taking proper consent from the families and the parents. I really wish that at the end of my presentations, we all should be able to understand why it is important to learn about atypical genitalia for every physician. Which baby we need to work up for atypical genitals? What is the difference between atypical genitalia and disorder of sex development? What are the underlying causes for atypical genitals? Practical diagnostic approach that we used to follow in our part of the world, and few case-based learning. So let's start with why it is important to talk about atypical. I think we all understand that pregnancy is a time when parents and the family, they're super excited about an outcome in the form of a baby boy and baby girl. And when a baby with atypical genital is born, this whole excitement turned into uncertainty and worriness. Being a parent, they could have a number of questions in their mind. Is my baby a baby boy or a girl? What shall I name my baby? Is my baby healthy? What should I tell my family? Am I responsible? And to whom I need to consult? And I believe being a physician, pediatrician, and neonatologist and endocrinologist, it is our job to be empathic but honest. One of the most common mistake that is being done in the developing country is that please do not hurry to assign a gender to a baby without workup. So you need to be honest with the family and state that you're not sure, is this a baby boy or a girl at this moment? So please do not hurry to name a baby. You can assure a family that you will maintain confidentiality, and you can tell a family it is a medical condition which need a workup, and then you can refer to a proper team who is dealing with the DSD, because managing a DSD and atypical genitalia needs a proper group of endocrinologists and a surgeon and psychologist who have expertise in it. Let me share with you again why it is important to do a proper workup and a timely workup for atypical genitalia, because consequences of misdiagnosis are really, really devastating. Let me share with you this baby who presented to us at a 2 month of an age with a concern of bilateral undescended testes. When we took a history, there was a history of three sibling deaths with the same complaint. And the investigation revealed that this baby was having 46XXCH, 21 hydroxylase deficiency. So imagine the family has lost three siblings just for a condition which could be easily detectable and manageable. The second case is a 10-year-old boy who presented in our A&E with a concern of hypertensive heart failure. And when our A&E team tried to catheterize a baby, a boy, and they feel that, oh, the genitalia doesn't look like a normal one, endocrine team is being involved, and this boy was having 46XXCH, 11 beta hydroxylase deficiency. Again, imagine that this is a preventable cause of hypertensive heart failure, but somehow because it is missed at the time of birth, and this 46XXCH lived as a boy for 10 years and end up with this long-lasting complication. Third is she's a girl who is 13 year of an age, presented to us with a concern of realization at the puberty. However, the parents somehow narrated that there was a concern of atypical genitalia at the time of the birth, but the local physician somehow assured them that nothing to worry about, it will settle at its own. And this girl was 46XY5 alpha reductase deficiency. Again, imagine this girl has spent 13 years as a girl and she was having 46XY. And you can imagine when we change the gender of the girl to a boy, how the family has gone through, especially in our circumstances. So it's very important to know the first important point, which baby you need to work up for atypical genital. That is the most common questions I came across by many physicians and neonatologists. So there's a one genitalia which is clearly ambiguous. You were unable to differentiate it's a male or a female. Definitely that baby need a workup for atypical genitals. However, if a baby is born with a male phenotype with any one of the following, this baby need a workup for atypical genitals. For example, absolutely normal male looking genitalia, but bilateral undescended or non palpable gonads, please do a proper workup for atypical genitals because you never know this baby is realized to an extent that the genitalia look like a male and actually this baby is a female. Second, if you have a severe hypospadiasis, proximal or perineal hypospadiasis, this somehow classify that this patient need a workup for atypical genitals. And the third is that if your baby is born with any degree of hypospadiasis with one more genital ambiguity, which could be a unilateral or bilateral non-palpable gonads or a microphallus, you need to work up for atypical genitals. Do not assume that the gonads will be in abdomen. Second is that if a baby is born with a female phenotype and the baby is having a clitoromegaly, clitoromegaly mean if the length of the clitoris is more than 9 millimeter and width more than 6 millimeter. Please make it sure that in a preterm, you can easily differentiate this clitoromegaly from prominent clitoris because many IUGR baby and many preterms baby, they do have a prominent clitoris which is being somehow confused with the clitoromegaly. Secondly, it's make it a habit to palpate the inguinal area and make it a habit to palpate the labial folds for every baby who is born because you never know the genitalia look like a female, but they could be a palpable unilateral or bilateral gonad. And third is anogenital ratio. So that is a ratio that you use to Okay, so this is the ratio from anus to the clitoris and from anus to the posterior foresheet. If this ratio is more than 0.5 and or if you have a single opening, then it also classify that this baby need a workup for atypical genitals. So important learning point from my physicians, doctors, pediatrician, please do not assume a gender of a baby by just looking at genitals because in first picture, the genitals look like a male, but this is a female child from karyotype and is an XX. And the second one is a male XY. And so that is very important. What is a DSD? That is a second most common questions that is being asked to me by postgraduate trainees and a pediatrician. What is the difference between a DSD and atypical genital? So DSD is a group of congenital disorder. It is a big term, a big umbrella term, where there is an atypical discordant development of either sex chromosome, gonads, or external genitalia. What it means, there could be a problem at the level of sex chromosomes. There could be a problem in formation of the gonads that, or the gonads could not be, there's a possibility they could not be coherent with the sex chromosome, or the external genitalia is not matching with the gonads and sex chromosome. If you look at the classification of the DSD, which was proposed in 2006, the classification of DSD start by karyotype. So sex chromosomal DSD mean when there is a problem at the level of sex chromosome. There could be absence of one sex chromosome like Turner syndrome. There could be presence of more sex chromosomes like Klinefelter, and you could have a chimeric picture or mosaic pattern. The other two types are XY and XX DSD, which mean the karyotype is normal, but the problem lies in the formation of the gonads, which means that in place of testes in XY, there could be a over testes or dysgenetic gonads, or in case of 46XX DSD, instead of forming a normal ovary, there could be a formation of over testicular DSD or testicular DSD. The second is that there's a problem in androgen synthesis. What it means, there could be a problem in androgen synthesis in a male or androgen action in the male, or in case of 46XX DSD, the problem could be in androgen access. And the third is the structural defect. If you look at this DSD classification, do you think that all of these different causes for DSD, they are present with atypical genitals? The answer is no. Turner syndrome, most common type of Turner syndromes, they bond with a female-like genitalia. Klinefelter, they bond with a male genitalia. Swire syndrome, though they are 46XY, but because they are complete gonadal dysgenesis, they were born with normal female-like genitals. Then you could have gonadal dysgenesis in a 46XX DSD. They could be born with the normal female genitals. So it means atypical genitalia is one of the clinical presentation of the DSD, and it's the most common presentation of the DSD. All the children with atypical genitalia are DSD, but all DSD do not necessarily present with atypical genitals. That is very important for learn and to differentiate. If you really want to understand that what are the causes, that how we can look for the different causes for atypical genitals, we need to understand how the genitalia is going to be formed in a fetus. A 4 to 6 week fetus, regardless of a karyotype, either XX or XY, it has a bipotential gonad, Wolffian duct, and Mullerian duct, genital tubercle, and genital fold. So if a baby is having 46XY, there was a SRY gene on Y chromosome that is responsible for basically converting a bipotential gonad into a testes. Testes have Sertoli cells and Leydig cells. Sertoli cells secretes Mullerian inhibitory hormones that causes suppression of Mullerian or regression of Mullerian duct and are responsible for the testicular descent. That is why the uterus is not going to be formed in a male. Similarly, the Leydig cell produce testosterone. This testosterone is responsible for proliferation, differentiation of Wolffian duct into epididymis, vas deferens, and efferents. And the same testosterone, it is converted by 5-alpha reductase to a dihydrotestosterone, which is then responsible for the virilization of external genitalia as a male genital. And the same Leydig cells also secrete inhibin, which are responsible for testicular descent. On the other hand, if the karyotype is 46XX and there is no SRY gene, the bipotential gonad, it formed into an ovary. The ovaries have no Leydig cells and Sertoli cells. So when there are no Sertoli cells, there will be no Mullerian inhibitory hormones, and the Mullerian duct, they're going to proliferate and form the uterus and cervix and upper part of vagina. Similarly, if they don't have Leydig cells, there will be no testosterone. So Wolffian duct going to be regress. And because there is no testosterone, there will be no dihydrotestosterone, and the genitalia of a female is actually a fetal genitalia. Though this all look very simple, that having a SRY gene is responsible for making a testes and no SRY gene is responsible for making an ovary, but actually it's very complex. For a bipotential gonad to form a testes, it is very important they should have a transcriptional factors which are favoring to forming the testes, and there's a need for suppression of pro-ovarian transcriptional factors, and that is why you could have XY and SRY gene and the gonad is not properly formed. Similarly, in the case of a female, there's a possibility that even the baby is having XX, but instead of an ovary, there's a formation of a testes and over testes or dysgenetic gonad, because there's a lot of different transcriptional factors which are involved in forming a proper ovary. So these are very complex mechanisms which everyone need to know. So we can say for a fetus to have a normal male-like genitalia, the fetus need a timed and proper exposure of androgen. And to have a female genitalia, the fetus needs no exposure of androgens. So it means atypical genitalia is going to be formed if on a male, there will be less androgen exposure. So the male are always under-virilized when they have atypical genitalia, and a female are always over-virilized when they have atypical genitals. So that is another important point. And then you have a conditions like over-testicular DSD, mixed gonadal dysgenesis, which are previously classified as a true hermaphrodites, where again you could have a ambiguous and atypical genitals. So let's start with about what are the causes of atypical genitalia in a female and 46XX. We have already discussed the female need a lot of androgens in utero to have a atypical genitals. So these androgens could come from the maternal causes, like the mother could be on some androgenic drugs, for example, progesterone only pills for threatened abortions. The mother could have a virilizing adrenal tumor. There's a condition called lutoma of pregnancy. All other causes which causes virilization of the baby, and they also virilize the mother. Similarly, there are placental causes like aromatase deficiency and POR deficiency. They both causes the virilization of the baby and the mother. So in both the maternal and placental causes, the baby and the mother, they both gonna virilize. The mother could have acne, hirsutism, voice deepening of voice. Then we have a fetal causes. Fetal source of excess androgen could be adrenal glands. So those causes of CAH, which produces a lot of androgens like 21 hydroxylase, 11 beta, 3 beta, glucocorticoid resistance. The baby female can have atypical genital. And then the gonads, instead of having an ovary, could have a testicular component like over testicular DSD, or it could be a testicular DSD, either dysgenetic or non-dysgenetic. And then the structural defects are always there. If you look at atypical genitalia in male, we have already discussed that male should be under-virilized. There's a less androgen exposure to have atypical genitals. I included hypopituitarism, though it's not a DSD, but we have seen many cases with hypopit who are having undescended testes. And when we did a workup, they are not the DSD, but they presented like undescended testes with hypogenitalia. Then there are conditions which have decreased testosterone production. The conditions which involve both adrenals and testicular, the testicular organs. It includes 3 beta HSD, 17 alpha hydroxylase, POR, star, and SLO. So these are the conditions where you could have increased ACTH and pigmentation. There could be salt loser. So that is a condition which involve both adrenal and testicular component. However, there are conditions which only involve the testicular decreased testosterone productions are testosterone biosynthetic defect in testes, like LH receptor mutation and other enzymatic defects. And there could be a defect in testicular developmental defect, like testicular regression syndrome, gonadal dysgenesis, and over testicular DSD. And this last one is you do have a normal testes, but the androgens and testosterones, they are not functioning properly, like in case of 5-alpha reductase deficiency and androgen receptor defect. It could be complete and partial. I think you all know that complete androgen sensitivity, they used to present normally as a female genitalia, say. So normally we used to see this patient around puberty with a concern of delayed puberty. And the partial androgen sensitivity and 5-alpha reductase, they are born with atypical genitals. So this another learning point for all my colleagues is that among all these huge list of the DSD or atypical genitals, CH is one of the one which could be life-threatening. So when a baby is born with the atypical genitals, every attempt should be made for its prompt evaluation. Moving towards what is a clinical approach? The first is history, and I think the history is one of the most powerful tool. You cannot ignore it. You need to ask about the history of failure to thrive, vomiting, loose motion, any darkening of skin, consanguineous parent, maternal history of virilization, mother history of medication, tumors, and family history of atypical genital, infant deaths, infertility, amenorrhea, and precocious puberty. Examination: is my baby sick looking, well looking? What is hydration status, pigmentation, any obvious dysmorphic features? What are vitals, length, weight, and BMI? Please examine the genitalia in detail. What is stretch villus length? How the labial scrotal fold look like? Number of opening, gonads location and position, anal opening, any sign of puberty, SMR staging, and scoring of virilization. So we normally use these two scores. Prader score is used for over-virilized female and EMS scoring for under-virilized male. Regarding investigation, that is most important part. Every baby who was born with atypical genitalia, they need ultrasound and karyotypic to confirm the sex chromosome and the presence of the gonads and internal genitalia. This is for every kid. The next is you need to rule out the CAH. So we do the blood glucose, sodium, potassium, gases, ECG. Here's another important point that the CH sol loser, they do not present as a sol loser for first 7 to 10 days of a life. So never assume having a normal sodium and potassium in the electrolytes within first 7 to 10 days means the baby is not sol loser CH. You could have you could have a sol loser baby which is going to be present later at 3 and 4th week of a life in crisis. Then you do a CH profile depending upon which type of CH you are suspecting. The most common CH is 21 hydroxylase. So we normally do the 17 OHP as routine. And in our country, we don't have 11 deoxy levels. So that is why we can't do it. If the baby is sol loser, check renin, aldosterone, and synactin test if needed. Once you exclude the CH, then you need to check gonadal function. The gonadal function could be checked by having LH, FSH, testosterone, and estradiol level unstimulated if the baby is in mini puberty, that is within first 3 to 6 months of the life. And after 3 to 6 months of the life, you need to go for ACG stimulation test to look for the testosterone production. And in certain cases, if indicated, we follow MRI, laparoscopy, and biopsy. Genetics is very difficult and limited in our part of the world, but we need to have a right diagnosis. And I feel this is a future for every DSD. This is a simple algorithm that we used to follow in our setup, that if we have a baby who is born with atypical genital and karyotype is 46XX, the first thing we look at the ultrasound. If the ultrasound is showing the uterus and the ovaries, we first did a workup for CAH because we know the baby is excess, the gonads are ovaries, the uterus is there. And if it's a CAH, we'll treat as a CAH. But in case if workup turns out to be normal, then we investigate and take a history again about history of maternal virilization, androgen exposure, any drug intake. And if all this history turned out to be not negative, then we start looking for that are these gonads which were somehow being documented as ovaries on ultrasound pelvis could have a testicular components. So we ask for repeat ultrasound. We start looking for biochemical evidence of testicular tissue in these ovaries by checking for testosterone level after beta HCG. And if we feel that the gonads are streak or the gonads are not properly formed or they have a testicular component, then we follow the diagnostic lepro and biopsy. But in case if in initial ultrasound, your ultrasonography somehow says that the baby is having one ovary and one testes or there's no uterus, then there's no sense in going for a CH workup. You need to think about abnormal gonadal development and you need to look for the workup for biochemical evidence of testicular tissue, and the diagnosis could be over testicular DSD or mixed gonadal genesis. Secondly is if the baby is having 46XY karyotype and again the genitalia look like normal internal genitalia, male one, without uterus, without ovaries, the first thing you need to look for the cause of the CAH. I would like to emphasize in Pakistan, 3 beta HSD is very common. So we have a huge number of undervirilized boys who are salt loser and they are CH and their 17 OHP is not that raised. So please make it sure to do a workup for CH in undervirilized babies also. However, if CH workup turns out to be negative, then you need to assess the testicular function test. We normally follow less than 3 months, but I know that till the age of 3 to 6 months, there's a mini puberty, and you can check the basal level of LH, FSH, testosterone, estradiol, dihydrotestosterone, AMH, and even. After the age of 3 to 6 months, because the mini puberty has gone, you need to go for beta ECG stimulation test. If there is a good response to testosterone, which means the testosterone level is more than 100 to 150 nanogram per deciliter, then you need to look for testosterone to dihydrotestosterone ratio. If it's more than 18 or 20, the most likely diagnosis is 5-alpha reductase. If it is less than 10, consider partial androgen insensitivity. However, if you have a poor testosterone response in beta HCG and your initial ultrasound revealed that having an ovary and the uterus, or then it means the problem lies in the development of gonad, or there could be a problem in testosterone synthesis. So in that case, we used to look at AMH and inhibin level. If the baby is having decreased testosterone and the baby is having decreased AMH, decreased NMN, and ultrasound is showing no gonad, dysgenetic, or suspicion of over-testes, diagnostic, lepro, and biopsy is an answer. You could find no gonad, you could find dysgenetic gonad, you could find over-testes, and you could have an ovaries. Similarly, if everything is normal, but there's a decreased testosterone production, then you need to think about LH receptor defect. The LH receptor defect could be easily detectable because when you check their basal LH deficit, the LH levels are sky high. And then you could have isolated testicular androgen deficiencies because they also present with having decreased testosterone formation. I'm just going to skip this detailed presentation of different type of CH because this is beyond the scope of my presentation. Regarding management, it is a multidisciplinary approach. You need pediatric endocrinologist, surgeon, urologist, geneticist, and psychiatrist. I'm not going into detail of management plan, but the medical management is basically mainly for CAH. You need to give hydrocortisone and fluticort if needed or not, depending upon sore loser status. First, do the gender assignment and then go for a surgery. These kids need support during puberty and the fertility assistance. There are two cases I'm gonna quickly go through, and this will be my last few slides for presentation. This was a baby I presented before, a 2-month old, failure to thrive with bilateral undescended testes, consecutive parents, 3 sibling deaths. And on examination, baby was dehydrated, and you can look at the genitalia, normal male genitalia, but you were unable to palpate the gonads. When we did a workup, ultrasound was showing bilateral ovaries and uterus. There was a hyponatremia, hyperkalemia, raised ACTH, and raised 17 OHP. Though karyotyping was awaited because you know that in our setup we have a huge number of DSD patients, and they got a long queue for karyotype. So we initially managed to treat it for adrenal crisis. The family was counseled, started hydrocortisone and florinef, and the karyotype was somehow done at 8 months of an age, and it was 46XX. So at 8 months, the baby was well thriving. Same finding, karyotyping was XX. The baby was presented in a DSD clinic. Family counseling was done, and it was decided as a joint decision in the best interest of the baby to raise as a female. But the patient lost follow-up. The same patient presented to us at the age of 10 to 11 years with height less than third centile, weight 50th centile, with this genitalia. The baby was having hematuria and he was having breast stage 3, puberty stage 4. The bone is partially fused. And now you can see because the boy was living as a male, this breast development is a normal puberty and the hematuria is actually the menarche that has started. So this patient was again discussed in gender real meeting, and the whole pros and cons of gender assignment was discussed with the family that if you want to read up as a female, though there are chances of fertility, but very less because somehow the baby has exposed to androgens for the last 10 to 11 years. There was a concern of gender dysphoria because he was identifying himself as a boy. If they want to read up as a male, he will be infertile, but less risk of gender dysphoria. Multiple psychological assessment of family and parents were done. He was started back on hydrocortisone and fluticort. Those were adjusted. And finally, it was decided to rear up as a male, and hysterectomy and oophorectomy was done for the same case. So this case shows that how a same case when they approached at the age of 8 months, the decision was different. But when the same patient presented at the age of 11 years, that was a different decision. This is the last case, case 2, a 3.5-year-old girl who was presented with atypical genitalia. She was diagnosed in a local hospital as a CEH and started on hydrocortisone at a very low dose and flutocort. There was just that documentation. The baby is having atypical genitalia. Ultrasound is showing a presence of uterus, no ovaries. 17 OHP was borderline raised. Sodium potassium was normal, and karyotyping was never done. So when we examined the baby was having, girl was 3.5 centimeter phallus. There was bilateral labioscrotal fold, fused posteriorly single opening. But the girl was having a hypertension of 130/90. We admitted the patient, we stopped all the hydrocort and fluticort, and somehow the serum electrolytes, RFT, synacthin, everything was normal. Renin was suppressed on prolonged beta ECG. She was producing a little bit of the testosterone. AMH was suppressed. Repeat ultrasound shows that there was a uterine tissue and right-sided ovarian tissue and left-sided atrophic testicular tissue, which was near to the iliac vessels. Ultrasound KUB revealed left-sided multi-cystic dysplastic kidney, and echo revealed this girl was also having coarctation of aorta with LVH. And when the karyotyping was revealed, the girl is having a mosaic pattern 45XO and 47XXY. So she underwent balloon angioplasty for coarctation of aorta. She had a laparoscopy which revealed Mullerian structure, right-sided ovarian hemorrhagic cyst, and left-sided oval gonads. Biopsy revealed right-sided benign cyst and left-sided primitive seminiferous tubule. So the diagnosis, which was initially made as a CH, is actually a sex-chromosomal DSD, mixed renal dysgenesis with unilateral dysplastic kidney and severe coarctation of aorta. It mimics as a Turner syndrome, so that is the whole picture, and it's very important to have a lateral thinking. So these my last slide as a take-home message. Atypical genitalia is a medical condition, not a stigma. Early diagnosis and multidisciplinary care are essential to prevent avoidable medical and psychosocial complication. Resource-limited countries need their own evidence-based, context-specific guideline for the evaluation and management of atypical genital. Gender assignment should be individualized, considering the diagnosis, age of presentation, future functional outcome, family perspective, cultural and social context, and ethical principles. Always prioritize the child's best interest. These are my references. And this is the data of my DSD clinic. In last 10 years, 1,083 cases of DSD has been reported to our center. And among them, every year we are seeing 100 and more cases. This is our wonderful DSD team, which have Professor Nabila as a chair. I'm a co-chair. We have a urologist, we have a surgeon, we have a psychologist. So it's a huge list which has been working for last 15 years for all these patients. This is my department, and my nurses, my doctors were the backbone for this DSD management. Well, thank you so much. And here's my wonderful city, Lahore, which is full of color, heritage, and history. And one day I'm looking forward to see you all at Lahore. Thank you so much.
Thank you so much, Dr. Somaya, for the informative and powerful presentation. And hopefully I can also visit you in Lahore one day. If
Yay,
anyone
looking
has
forward to
if anyone have question, please drop them in the chat and we'll get them during the Q&A. And next, I'm pleased to introduce our next speaker, Professor Martin Koos. Professor Martin Koos is a full professor and head of the Pediatric and Adolescent Endocrinology and Diabetology unit of her institution and senior clinical investigator. She coordinates the Ghent University Hospital Center for Sex Development and its multidisciplinary DSD team. Her research interests include gonadal development, DSD management, and cancer risk assessment. And she supervised 9 PhD students and co-authored more than 150 original papers, invited review and book chapter, mainly in the field of DSD and gender variant. And Martin Kool received the SP Young Investigator Award in 2010 and the Prix Burkert for Medical Scientific Research in 2020. Professor Koos is also actively involved in international networking, including Indo-ERN and SP, and serves as an advisor on DSD and transgender healthcare. So now time is yours, Prof. Koos.
Thank you very much for this kind introduction. I will try to share my talk, which I first need to find. I think it's here. Can you hear me?
Yes.
Okay. And now I need to put the screen mode. Oh. So I think it should be fine now. So thank you very much, Agostini, for your nice introduction. Hello, everyone, wherever you are and at what time of the day you are. Thank you, Somaya, for setting the scene so much. You made my life a lot easier because I think I will need a lot of the knowledge you have distributed for this presentation, which will be about germ cell cancer risk in DSD. And you may know that there is a big difference or a big evolution in the approach towards managing the risky gonad, where we did prophylactic gonadectomy in all cases with a Y chromosome a while ago. Now we try to have an individualized case-by-case approach. And yeah. And before I start to explain about the management, I would like to tell you that the cancers that we see in DSD, these are cancers from the germ cells. So these are germ cell cancers arising from late primordial germ cells or gonocytes, which have retained their pluripotency beyond the normal window of maturation. So normally, the pluripotent germ cells are only present during embryonic life. They can give rise to any tissue of the body. But of course, at a certain time point, they should become committed to the germline and should only generate gametes. But in DSD, it happens, as you will see, that this pluripotency is retained for a much longer time. And the reason is not so much because the germ cells themselves are sick, but it is a problem actually of the supportive cells, so the cells that should have become Sertoli and granulosa cells, but that fail actually to control this normal developmental program of the germ cells. And in all DSD cases, these cancers do not arise all of a sudden. They remain quiescent for many years as in situ lesions called germ cell neoplasia in situ or gonadoblastoma. And then all of a sudden, they may become invasive. And so, as I said, they arise from these pluripotent germ cells, and pluripotency is a marker that can be indicated by this OCT4 staining on immunohistochemistry. So all these brown spots are cells that have retained this pluripotency marker. And you see here a testicular environment where some of the cells are brown, and over time they may develop as a germ cell neoplasia in situ. This gonad, you cannot easily recognize it as a testis. There are no testis tubules. There are also no ovarian follicles. We call this, you will hear that later, undifferentiated gonadal tissue with a lot of germ cells that are laying a little bit scattered over this gonad. And this is the situation where gonadoblastoma will mainly occur. Before I start explaining about germ cell cancers, I would like to introduce two tools that may be of help for you. And the first one is the external genitalia score. This scoring system is based on the external masculinization score that Sumaya has presented already. It's actually kind of similar, but it uses a totally gender-neutral vocabulary. So you see here labioscrotal folds, genital tubercle, for example. And you can use it for any baby, whether it is looking more like a girl or whether it is looking more like a boy. The scoring is up to 12. And we have validated this scoring system in a very wide population and even also for preterm births. And we have made normal reference values for this EGS score. And we have also investigated, so Sumaya has explained when to refer a baby, when should we think about a DSD. Well, if you use this score, it is actually very easy because all the babies with an EGS score that are below the 10th percentile, meaning usually in most cases, depending on the birth rate and on the prematurity, it means mostly that they have a score of equal or below 10.5, or when the baby is looking like a female, the score, when it is higher than 0, it should be referred. So look for the paper, it is freely downloadable, and if you can't find it, you can always alert me. Another tool, I think, is this kind of diagnostic decision tree, which we have presented in a GCM paper last year. where we highlight the approach towards DSD or to diagnose, and we really offer a stepwise approach where I think you can come already quite far without doing genetic testing, for example, apart from the karyotype, and where you can at least discriminate between forms of gonadal dysgenesis or forms of hormone synthesis or action problems, because this is really crucial if you want to think about a management plan for the gonads. So the first step, let's look at the cases with isolated, not the syndromic DSD, is that you do karyotyping. And I think I have understood from Somaya's presentation that this is usually not too difficult to obtain. If you have a variation of the sex chromosomes, you're done with the diagnosis, then you can have XY or XX DSD. And then the most important test is to do an ultrasound to define whether there is a uterus or not. And depending on the results and on some very, very limited hormonal tests, you can really discriminate between all these forms of DSD. And the most important one, I hope, if you would go for one test, then the anti-Müllerian hormone is really very crucial. Apart from that, of course, we also need usually LH, FSH, and testosterone. And of course, when we think about CAH, the 17-hydroxyprogesterone is also very important. So this will allow you to discriminate between gonadal dysgenesis and between the various forms of hormone synthesis or action problems, even without any of these specific genetic testing. You can, of course, do a genetic test, either a targeted sequencing test, or if available, you can collaborate with someone who can do whole exome or whole genome sequencing. So now I would like to introduce to you what it is actually this case-by-case approach in which we try to manage the gonads. And I will present briefly 4 cases to you. One girl, 17 years old. She has no puberty, so no breast development. She has sky-high LH and FSH, and she has a karyotype 46XY. So we know that she has complete gonadal dysgenesis just by this karyotype, by the very elevated gonadotropins and the fact that she has no breast development, because if she would have had complete androgen sensitivity, she would have breast development. So this is very crucial to discriminate. And we decided for her to do bilateral gonadectomy quite soon after the diagnosis, and she had bilateral gonadoblastoma and dysgerminoma. This is a boy, 1 year old. He had a good virilization overall, 7 out of 12 on the EGS. He had bilateral inguinal gonads and penoscrotal hypospadias. His karyotype was 45X46XY, sex chromosomal mosaicism. And for the inguinal gonads, we did surgery trying to bring these gonads into the scrotal position. On the right side, this was possible. On the left side, this was not possible. The vascular bundle was too short. The gonad looked very dysplastic. And our surgeon immediately decided to do an orchidectomy on that side. And this child now grows up. And at puberty, he will start to do self-palpation on his right testicular, on his right testis, which is in the scrotum, and he will have an annual ultrasound. The left gonad really looked very dysplastic. The right gonad looked as a testis. You can recognize the testis tubules, and you will see that here and there, very difficult to see, there are some of these OCT4 positive cells, so these pluripotent germ cells, which are a little bit of worry for us, but still we think this gonad is functional, is important for this boy, so we decide to keep it and to follow. This is a girl, 1 month old, with very, very little virilization. She has bilateral inguinal gonads, and she has no uterus and a karyotype 46XY. Yeah? And because she has no uterus, we already know that probably she has a defect of synthesis or action of testosterone. So we do some genetic testing after the hormonal assessment, showing that she has 17 beta HSD deficiency. We didn't do any gonadal intervention until she grows up. While growing up, we see that she develops a female gender identity. And at the age of 9 years, you've seen several times with a psychologist, after I had explained her the diagnosis and that she will virilize at puberty, the psychologist really made this very clear for her in several sessions, because a girl of 9 years old, it is difficult to understand at once, of course. And they explored together, like, what would this mean for you if your body would virilize, and how would you feel, and is this what you want or you don't? Well, in the end, she decided that she didn't want that she really had a female gender identity, and she provided her agreement, her consent. She wanted actually gonadectomy, and we did this at the age of 10 years. She had a lot of germ cells in her testes, all these DDX4 positive brown cells. Another marker, again, this OCT4 pluripotency. She has a lot of these pluripotent OCT4 positive germ cells. And later in the presentation, we will see that what we also think important, apart from staining, is the place where these OCT4 positive cells are. These cells are mostly stick to the basal membrane and not more towards the center of the tubule. This one is one who is not stick to the basal membrane. And actually, we are much more worried about this one, who is close to the basal membrane, than this one, who is more in the center of the tubule. I will explain later. And then the final one, a girl 9 years old, she has a little bit more virilization, bilateral labioscrotal gonads, again, no uterus, XY. We know that she has a disorder of synthesis or action of the androgens. And indeed, genetic workup shows she has partial androgen sensitivity syndrome. She has very, very limited virilization. So we know that this is a very severe form of partial AIS. She also develops a female gender identity. And we decide together with her to do no gonadectomy if no virilization occurs. It remains to be seen. She's now 11, 12 years old. She has started puberty, breast development. So far, her clitoris is not growing, and she prefers to keep her gonads because this is her natural source of estrogen, because the testosterone is converted in her body to estradiol, which gives her breast development. And we will try to follow up on her gonads with annual MRI and with tumor markers. This is not her gonads, because I said we didn't do even a biopsy, but what I would expect for her is that she has also OCT4 positive cells, but not towards the basal membrane, like in this case, but really in the center of the tubule. And you will see I'm not so worried about those. So what do these 4 children have in common? They all have a Y chromosome. And that's important because in DSD, the ones who are at risk for germ cell cancer, they have Y chromosomal material. Not the whole Y chromosome is important, but only one gene, TSPY, which is quite close to the centromere. You see that is quite far away, at least from a genetic perspective. It's quite far away from SRY. So this means that if you have a boy, for example, with XX testicular DSD, due to a translocation of SRY to the X chromosome, this boy is not at risk for developing a germ cell cancer because he doesn't have TSPY. TSPY is somewhere else on the Y chromosome. Practically, the ones who are at risk are the ones with 45X, 46XY DSD, and the ones with XY DSD. Two important groups here, the ones with a problem of gonadal development and the one with a problem of androgen synthesis or action. And actually, this group has a very, very much elevated risk as compared to this group, and I will tell you why. Because there are important differences in these children. So this is the scheme of sex development. First step, the genetic sex determined at the moment of fertilization. Then the differentiation of the bipotential gonad into a testis or into an ovary. There are a lot of genes important for that. They need to promote testis development in the case of SRY presence, and they need to suppress ovarian development. But if this suppression of the opposite pathway doesn't work very well, then this can give rise to gonadal dysgenesis. So every gonad that has not differentiated into a proper functioning testis or a good functioning ovary has gonadal dysgenesis, is somewhere here on this axis. If the gonad has developed towards a testis, it will produce hormones, testosterone, and anti-Müllerian hormone, which will cause virilization and removal of the Müllerian remnants. Of course, if you have a source of adrenal in each individual, this child can also virilize. So the hormones will determine the third step. Our case 1. The girl of 17 years old, she has a complete gonadal dysgenesis, which we know has a very elevated tumor risk. The second one, the boy of 1 year old, he had 45X, 46XY, so at the level of the genetic sex, he also might have quite an elevated risk. And case 3 and case 4, they have a hormone synthesis or action problem, so they are totally different on a totally different place of this scheme, and they have actually a much lower risk, especially for AIS. This risk has been determined as being very low. For 17-beta HSD deficiency, there are very limited data. So this is actually the scheme that we just showed, but then translated towards the level of the gonad. So first of all, the bipotential gonad, which has formed around 4th, 5th week of gestation, which should develop into either a testis or an ovary. Once the testis is there, it will produce hormones. And this development goes under the influence of a whole complex network of genes. Most important ones are SOX9 and FOXO2, SOX9 promoting the male pathway, FOXO2 promoting the female pathway. And very importantly, they should be lifelong expressed and they should suppress each other. Otherwise, this can again give problems with gonadal functioning. So all the supportive cells in the testis will express SOX9, all this brown staining here, and all the granulosa cells will express FOXO2, and none of these supportive cells will express the opposite marker, unless if you have ovotesticular DSD, which is actually a very special form of DSD, because there you have actually a normal functioning testis and a normal functioning ovary within the same individual. And importantly, in the ovotestis, here is the difference, the transition from the testicular part towards the ovarian part, and you see the testicular part expresses SOX9, and the ovarian part with the follicles, it expresses FOXO2, but the opposite part will not express the opposite marker. So what happens in gonadal dysgenesis? So the forms that of DSD where the gonad has not properly developed into either a testis or an ovary, it can come along the male pathway, but not until a fully properly functioning testis. The testis tubules are very irregular. They have only small tubules with a lot of branches. Even here, it's even worse. A lot of interstitial space. And if you do this SOX9 and FOXO2 staining, you see that both markers are expressed within the same cell. So there is SOX9 expression, but this gonad does not manage to suppress the FOXO2 expression. Similarly, the gonad can embark upon the female pathway, can have this ovarian type stroma. If we do SOX9 staining, we can see some very primitive sex cord-like structures, but these are only very rudimentary. And usually, if we have gonads that are of a little bit older age, you see that actually this gonad has become like a streak gonad. There are no functional cells anymore. But importantly, when we have these kind of gonads, very, very undifferentiated with primitive sex cord-like structures like here or here, either on the male pathway started or on the female pathway started, but really blocked into this early stage of development with equal expression of SOX9 and FOXO2, these are the gonads that have the highest cancer risk and that are, of course, also not functional. They do not produce any hormones. In this female-looking context, you will more often find gonadoblastoma. When it is started on the male pathway, you will more often find germ cell neoplasia inside, both at quite high incidence. This is different from conditions where the androgen synthesis or action is a problem. Because there the gonad has, first of all, fully differentiated towards a testis. And what is the function of a testis? Well, in normal development, the primordial germ cells, they arrive in the developing testis, first of all, in the center of the tubule. There they are called gonocytes. They are still pluripotent. And then in the next months of pregnancy, they move towards the basal membrane, they make contact, and at that level, they lose their pluripotency. So as I said in the beginning, normally pluripotent germ cells should not be there anymore around birth, and then they can start spermatogenesis later on. And this whole process of maturation of the germ cells is really supported by the Sertoli and the Leydig cells, so androgens are needed for that. And in conditions with testosterone synthesis or action problems, these like in AIS, for example, you have proper testis development, but you have no androgen action. And so what happens is that these gonocytes remain in the testis in the center of the tubule with expressing OCT4. They remain there for many months, even years after birth, whereas they should have disappeared already around birth. So what is their natural fate? Well, most of them will just die. And so when you have a biopsy or gonadectomy material of an older individual with AIS, usually there are only a few islands, patchy islands of germ cells left, and they will over time probably also disappear. So in AIS gonads, if you would look for germ cells at the age of 30, for example, I would be quite sure that there are almost no or maybe no germ cells left anymore. Unless something else happens. And what is that? Well, we start to get a little bit nervous when some of these germ cells do make contact with the basal membrane and they do not lose their OCT4 expression. And you see in normal development they do, but here in this developmental step they don't do. They make contact with the basal membrane and here they keep on expressing OCT4, which is this blue marker. Also some germ cells remain in the center, and there they are in their more or less natural environments while still expressing OCT4, but here they fail actually to commit to the germline. And we believe, we have no strong data for that, but we believe based on a lot of research that actually if a germ cell neoplasia in situ will develop, it will be from these specific germ cells that make contact with the basal membrane and fail to lose pluripotency. So if we look at it schematically, we have two different situations. One situation where the gonad did not reach testicular or ovarian proper development and function. And the more undifferentiated it is, the higher the risk for germ cell cancer development and the lower the gonadal function. And on the other hand, we have forms of partial gonadal dysgenesis with gonads that have almost become a testis, that produce a lot of testosterone in boys who are well virilized. So it's important for them to keep their gonads. Or when the testis has fully developed, there can be a problem with hormone synthesis or action. And you see that in these situations, the gonadal function is quite high and important for the child, whereas the germ cell cancer risk is very low. So of course, when you have high risk and no function, it is more logic to do gonadectomy. And when you have low risk and high function, well, then you would try to develop a kind of surveillance program, especially if the child, if you know that this family will show up again and will not be lost to follow-up. This more or less theoretical model has been confirmed based on a lot of epidemiological data that we have collected ourselves. And I will not go into details here, but we did a study a long time ago, 2006 already, where we did some risk estimation, and we could now say after 20 years later that actually the risk estimation that we did was quite good for these gonadal dysgenesis, up to 40, maybe sometimes 60%, especially in WT1 mutations. But in AIS and in over-testicular DSD, this risk estimation was probably too high, and the real risk is probably much lower. This is an interesting study because it looks at, well, if you have a risk for developing germ cell cancer, when will it occur? And they developed some Kaplan-Meier curves, and the first one shows you, well, what is the age of developing germ cell neoplasia in situ. This is the highest risk group, and you see that the germ cell free survival starts to decline around the age of 11. And here, this is the invasive cancer, and this starts to decline. So the germ cell tumor free survival time starts to decline at around the age of 60. So if you cannot do gonadectomy at the age of 2, for example, don't worry, because there will be no tumor. It will come when the child is 15, 16 years old, sometimes 20 or 25. Not below 15 or so, it will not be invasive. We also looked through some specific research setups at germ cell cancer risk in specific groups. The first one here, 45X, 46XY. We looked at 87 gonadal samples, and we divided our patients, 48 patients, into 3 groups, depending on their degree of virilization. There were the ones who presented as typical females, so with Turner syndrome, but with a karyotype 45X, 46XY. The ones who had good virilization with an external masculinization score of 7 or more, and then the ones with an ambiguous phenotype with an EMS score below 7. And what we saw was, depending on the group where they belonged, their cancer risk was quite different. We tried to estimate what is their risk for cancer by looking at their gonadectomy or biopsy material, and we looked if we could find signs of gonadoblastoma, germ cell neoplasia in situ, or also this high-risk undifferentiated gonadal tissue. In the girls with Turner syndrome, it was not very often present. In the virilized boys, well, around 10% of gonads had an elevated risk, and in the ones with an ambiguous phenotype, 50%, half of them were actually had one of these risk markers. So this is a high risk, and the reason for this is, of course, that the external phenotype of the patient actually is a mirror. It reflects the internal differentiation degree of the gonads. The one who had female phenotype, the Turner syndrome, they mainly had streak gonads, sometimes regressed gonads, but no undifferentiated gonadal tissue, or very few of them. Whereas the one with good virilization, they mainly had testis. Some of them had undifferentiated gonadal tissue or testis in combination with this UGT. And the group with the ambiguous phenotype, they had half of their, as you consider the group, half of the gonads were actually this kind of high-risk gonads with UGT in combination with testis parts sometimes. And so if you look at your patient's phenotype, you already know a lot about the cancer risk of this patient, if in the group of patients with 45X, 46X. For patients with androgen insensitivity syndrome, we know that the cancer risk is very, very low during childhood, that it is important for them to keep their gonads because it will produce testosterone. The testosterone will be converted to estradiol, and they will have breast development, they will have spontaneous puberty. Of course, they will not have menstruation because they have no uterus. But it's better for their bone health, it's better for their general health. They don't need estrogen supplementation. So it's good to keep their gonads, but can we keep them also into adulthood? Well, we know that the tumor risk is very low in childhood, actually non-existent. But what happens in adulthood? So we looked at 52 postpubertal individuals who had gonadectomy at a median age of 17 years, so still quite a young group actually. They had a genetically confirmed diagnosis of AIS, and 42 of them had complete AIS, 80 samples, and then there were 10 persons who had partial AIS. And what we found was that actually from this whole group of almost 100 gonads, there was not even one single gonad that had an invasive cancer, not even one that had a germ cell neoplasia in situ, but there were some gonads who had this pre-germ cell neoplasia in situ, meaning that there were OCT4 positive cells that made contact with the basal membrane, but did not lose their OCT4 expression. And the mean age at gonadectomy, the median age was 16 years. And we think that actually they are at very low risk to develop more invasive cancers due to the fact that they have no androgenic effects. As I've shown you in one of the previous slides, actually the tumor development starts around the age of 15, 20, and this is due to also the androgenic effects in puberty, or maybe also from the one that we give, like hormone supplementation. But of course, in this women with complete AIS and also in partial AIS, there is a very limited androgen action. And also we looked at some genetics markers, SNPs, if we could see, well, do they have risk alleles for development of germ cell cancer? Do they indeed have these pre-germ cell neoplasia in situ? And we found that it was a little bit helpful, but overall not really useful in the clinic. So no genetic investigation apart from the diagnosis of AIS, no genetic investigation needed. So based on these results, we developed a decision tree how to manage gonads in individuals with complete AIS and also in individuals with partial AIS. The bottom line is in complete AIS, in childhood, no risk at all. So please leave the gonads in situ, and then around puberty, you will see that breast development will start. You can discuss with the child when the young woman, when she is like 16, 17 years old, depending on your circumstances. If you have no possibility due to limited resources, for example, I think the knowledge on adult outcome of gonads is still limited, and it might be a better decision to remove gonads at that time. If there is a possibility to follow them by ultrasound, MRI, tumor markers, you might consider that. I refer you to the articles to really go into the details. For partial AIS, situation is a little bit more complex. For example, in a boy with partial AIS, well, it will not fully act, but there is some limited action of testosterone, and the testes will produce massive amounts of testosterone. So it's important for this guy to keep the gonads. And the good thing about testes is that they are in the scrotum. If you can fix the gonads in the scrotum, then you can follow them by self-palpation. Just like women, they feel their breasts to see whether they have no breast cancer. It is very important for boys with an elevated risk for germ cell cancer to just self-palpate their testes from the age of 12 onwards, for example. And you can easily do an ultrasound, which is also accessible, I heard. And so it's much easier for follow-up than an intra-abdominal gonad in the case of guys, for example, which you cannot really see with ultrasound. And by the way, even if we do MRI in women with complete AIS, we think we are on the safe side because MRI is considered the golden standard, but MRI actually cannot detect a germ cell neoplasia in situ. So that is also what I try to explain to the girls that I follow with complete AIS. They want to keep their gonads, they don't want to have gonadectomy. And I need to explain them, well, you have to come back every year for an MRI for tumor markers, and these are not very reliable. If you have an invasive cancer, we will see it on the MRI, we will see it by the tumor markers, mostly, not always, but we cannot see the germ cell neoplasia in situ, where it is still safe and will not have become invasive. So the serum markers also, they have low sensitivity. So really the surveillance of gonads at risk, especially from abdominal gonads, is very difficult. We just rely on the fact that actually in complete AIS, the risk is very low. But very often you will end up with a gonadal biopsy. It's important to consider if you do this, how to do it and when to do it. And it's not very useful to do it a few weeks after birth, because then even in a normal situation, some OCT4 positive cells may still be there. But if you do it, for example, at the end of puberty, there might already be a large germ cell neoplasia inside the lesion, which you can see if you do an extensive biopsy, and not a very, very small one, because that is too small. Actually, you need to consider at least 30 tubules, and if the gonad looks different from both sides, well, then you need, of course, to biopsy several parts. But you need to be aware that even without appropriate staining, so just by H&E, and also because your pathologist will not have a lot of experience with DSD, many of these lesions will be missed. And I will, in my last slide, tell you how you can solve this problem. But if we look at gonadal management and individualized management, you know by now that there are a lot of things that we take into consideration before designing. And in this paper that I already referred you to, you will see that there is this kind of decision tree if you have 46XY DSD or the DSD, it should say gonadal dysgenesis, not DSD, but gonadal dysgenesis. And if you have sex chromosomal DSD, well, then depending on the phenotype, with a female phenotype, mostly this comes to the fact that there is complete gonadal dysgenesis. So you know that the gonad is not functional at all. It will not have follicles. It will not produce any hormones. It only has a high cancer risk. So please remove this gonad. It is of no use for the patient. But if the patient has a male phenotype and you can bring the testis in a scrotal position, then it is worthwhile to keep it because it will produce some hormones, even if this patient has testicular dysgenesis. The testis will not function fully properly, but at least it will provide some hormone production. And you have very good ways of following it by self-examination and by annual ultrasound, and consider eventually a biopsy. If you have a patient with an ambiguous phenotype, with gonadal dysgenesis or with sex chromosome mosaicism, well, then again, your trigger to do gonadectomy of a most dysplastic gonad should be very high. Sometimes these patients have, for example, one testis in the scrotum and one gonad which is inguinal or abdominal. The surgeon can already, by looking at this gonad, see that the one looks much better than the other one macroscopically. And usually the vascular bundle is too short to bring it into the scrotal position, so you cannot follow up by ultrasound, for example. So please remove that bad gonad and keep the one that is properly functioning, or eventually you will have to remove both of them. And when you have a problem with biosynthesis defect of testosterone or AIS or over-testicular DSD, well, actually, your decision to do gonadectomy or not will more likely depend on the gender identity of the child and not so much on the cancer risk, because the cancer risk in this group is much lower. Over-testicular DSD is almost always associated with an XX karyotype, so no increased tumor risk, even if they have testicular development. But of course, if the child identifies as a girl, then you should remove either the testicular part, or if it's not, it cannot be separated from the ovary, then you have to remove the whole gonad, of course. If the child has complete AIS, I have already discussed. If the child has a male gender identity with over-testicular DSD, try to remove the ovarian tissue. Otherwise, try to bring the gonad in a scrotal position, for example, in boys with partial AIS or with 17-beta or 5-alpha reductase deficiency. But if this child has a female gender identity, well, the reason to do gonadectomy will mostly be because they don't want to virilize, and then you will have to remove the gonads and give hormone replacement therapy. And so this is my team. I would like to thank all of them. I would like to thank you for listening. And I would also like to raise your interest if you have paraffin-embedded tissue of your patients and you would like to have a second opinion, you could always send me the paraffin blocks. We do second opinion for free. And so if you want to participate in research, this is possible. But if you just want to have the clinical advice, this is also possible if you send me the paraffin blocks for it. And thank you for listening. I'm open to listen to your questions.
Thank you very much for the excellent presentation, Prof. Martin Kool's.
Oh, I will stop sharing.
And I'm certain our participants are eager to ask their burning question. With that, we will begin our discussion session. So please, Anissa, to share the question from audience. So this is the question from Afnan to Dr. Somaya Aftab. A male infant with isolated epispadia has normal LH, FSH, and testosterone concentration during the mini-puberty period and normal serum electrolytes. Is any further endocrine workup indicated?
Okay, thank you so much, Afnan, for asking such an interesting question because we really need to know when not to investigate. That is more important because as we have discussed, if you have a simple distal hypospadiasis or epispadiasis without any other genital ambiguity, like if the phallic size is normal, the gonads are in the scrotum is well formed. Honestly, to the best of my understanding, this patient just refer to a urology. They does not need any further workup, and especially epispadiasis is more of a structural defect. So for that patient, no further endocrine workup will be indicated, provided the genital appearance, the phallus size, and the both gonads are within scrotums. But if you have one more ambiguity, maybe microphallus, and you have undescended testes, it's somehow categorized as atypical genitals, and then you need a workup for atypical genitalia.
Okay, thank you, Somaya. I think it's very clear. And next question. How to do postnatal screening of a neonate who has a brother with CAH?
So I know that in most of developing countries, we do not have a NBS program and we do not have dried a filter paper Guthrie test available. But I think if you have one patient with CAH, if they have a sibling, either boy or a girl, atypical genitals and normal genitals, they should have done 17-hydroxyprogesterone level after 72 hours of life. This is most important. Within first 72 hours of life, you could have a falsely raised 17-hydroxyprogesterone level. So you need to make it sure that you should not concede this, you should not mix this normal level with a diagnostic level. So after 72 hours of life, the boy or the brother should be checked for CH.
Okay, so thank you. I think it's also very clear about the screening of a neonate who has a brother with CH. And I think the next question, this is for Dr. Martin Kool's. How frequently has the genetic marker evaluated in suspected gonadoblastoma? And the second question, genetic testing or gonadal biopsy, which is better, considering the size of the gonad is very small?
For the second question, genetic testing, I already explained to you that actually whether this child has an SRY deletion or a WT1, well, that is important. You can, of course, follow up. You need to check for proteinuria, for example. But an SRY deletion, a SOX9 deletion, another cause, GATA4 mutation, whatever, actually that doesn't matter. And so as long as you know that the child has gonadal dysgenesis and no testosterone synthesis or action problem, which you can exclude by hormonal test, you don't need genetic testing for that. Well, if you know that your child has gonadal dysgenesis, it doesn't really matter what kind of genetic defect lays behind. So I would go for a gonadal biopsy. But of course, gonadal biopsy, you cannot do this 50 times because then you have no gonad anymore. If the gonad is in the scrotal position, if the child is well virilized, then you consider that it is partial gonadal dysgenesis with relatively completed testicular development. And then I would rather go for a biopsy at the end of puberty. The gonad is already in the scrotum. You can follow it by ultrasound, by self-palpation. But any gonad that is in the abdominal or in the inguinal position, you need to do an orchidopexy. You will already see during the surgery that some of these gonads are very poorly developed and have a very short vascular bundle. It's probably not even possible to bring this down to the scrotum. Then you could take a biopsy, or if the gonad really looks very unhealthy, you can better remove it right away. And for the first question, I think I don't really understand the question. How frequently has the genetic markers evaluated in suspected gonadoblastoma? I must say that I don't really understand the question.
Or maybe the marker of the tumor marker, maybe.
The tumor markers that we have in the blood are alpha-fetoprotein and beta-ACG. So in post-pubertal individuals, I check that every year. In those who still have their gonads, but I also explain them that especially when there is just a gonadoblastoma or a germ cell neoplasia in situ, so just an in situ and not an invasive lesion, then it will not be elevated. So it will only be elevated if you have an invasive lesion. So the other means that we have, mainly self-palpation, ultrasound, for testes that are in the scrotal position are much more reliable actually than the tumor ones.
Okay, so thank you, Martin. And the next question, this also from Dr. Menon. Is there a moratorium for genital surgery in your country?
No, there is no legal. It's not legally forbidden to do it, but there is a lot of. It's highly controversial to do it. If we would do it, we would really get the noise would spread very fast, and a lot of activists would really make a lot of noise. And also, the government is trying to develop a legislation to make it kind of illegal. But I must say that. I'm not in favor of a legal ban of genital surgery, because I think in very limited number of children it has a place. But it is more the way that we approach new parents. For example, we never approach new parents with the urologist or the surgeon. It's only the psychologist and endocrinologist who go to their parents. We don't even talk about the possibility of genital surgery. We just say the gonad looks atypical, the genitals look atypical, and we will try to find the cause. And it's very important for you as parents to process the diagnosis and to have good bonding with your child. And later on, we will see how we will deal with the atypical genitalia. And the words you use and the way how you can show to be comfortable and that you have experience with this situation, this will really reassure the parents. Even also, we have really a lot of children who are from other ethnic or cultural or religious backgrounds. And we also try to really think with their eyes. Sometimes parents say, yes, but God or Allah decides how the child has developed and what is the gender of the child, and we don't want to have another option. There are only two options. But then we say, well, but yes, Allah decides, but sometimes Allah decides not at birth, but just later on. For example, at the age of 10 years, Allah will decide and you will see. And you will get a clear sign from God if your child is a boy or a girl, and then we can still do the surgery. And this is really helpful for parents.
Yeah, thank you, Martin. Maybe this is the thing that are very different in some countries. For example, in our country, maybe also in Somalia, because in our country they want to do it as soon as possible.
I know. And sometimes people have
Very
traveled
difficult,
all
yeah.
over the world because they want to have surgery. So sometimes they arrive with a child 4 years old in our country after, well, they might come from Syria, from Pakistan, from all over the world, and they come here and they have just one question. We want genital surgery for a child, and then the problem is solved, and we will never need to come back anymore. And it sometimes takes years to work with the parents, but usually we can manage the situation with gaining some time and with explaining and with helping both parents and child. And we recently had a child, for example, who was in that situation, who came from Syria, came as a girl, and now this child is 12 years old, and the parents see him as a boy now, and to really accept him, and are very happy with their child, who is now a boy. And this child really indicated already from the beginning that they did not want to have surgery. And we thought it was very important, first of all, to change this, to explain to the parents, like, well, it's not because we do the genital surgery that the problem is fixed. You will still have to come. Your child needs actually gonadectomy. There is a high cancer risk, but for the surgery, there is not an emergency. And you will need to come back to the clinic. Your child will need medication. Your child will never be fertile as a boy. It took with an interpreter and so on, very difficult. It took really years for us to gain the confidence of the parents. But I am sure that 10, 15 years ago in our country, it was very similar to your countries, but by changing our approach, by not approaching the parents anymore with the surgeon, by not talking anymore about genital surgery from the beginning, just talking about other things and reassuring the parents that they can do this situation and that we know how to do it and how to support them, and that the most important thing is that they love their child and that they accept their child, how it has developed. It changes quite rapidly. I mean, over 10, 15 years of time, the attitude of parents nowadays is different, and it was very similar to your situations only 10 years ago.
Okay.
So honestly, I just need to put a little bit in our part of the world how we are managing things, because we know that most of the investigation and the surgeries and everything, they are not free of cost, and the parents are very poor, and they have 5 and 6 kids, and sometimes 2 and 3 are being affected because of a huge number of cousin marriages. And even what we were facing in Pakistan, that even if we try to delay the surgery sometime, we being a DSD team receive a legal notice from the parents that we want the surgery to be done, and this family, the doctors are not happy to do that. So what we were doing now, so we have started making our own guidelines, so that once we have a fixed guidelines that is for the best interest for the patient, so at least we can show them some legal evidence that why we were saying this, because that is a huge problem we were facing in Pakistan, that we were receiving, being a physician, legal notice by the parents that they were delaying our kids' surgery and we want it to be done. So that is another side of the picture, because now the people are getting more aware of it. We were delaying surgery. So that is why I really feel that we need to have a separate sort of a group of people who need to think about it, make certain guidelines, and then we can show the parents that this is actually for the best interest for their kids. That is the reason. And I agree with you, Martin, because the things has advanced so much in your part of the world. The people are very they're literate, they understand the underlying reason. But when we talk about Pakistan, India, most of the families, they were not that much educated. They just want to get a surgery done. The difficult part is even after the surgery, sometimes they stop the medication. And I was like, please continue the medication. You need to have this medication. So these are the challenges, but I agree we need to come to that point where we can follow the same guidelines that is being done all over the world.
Okay.
Perfect.
Okay, thank you. So I think this fruitful discussion about time for the surgery, it's very interesting. And this is the I think there is another question related to this also. Please let us know at what age would definite surgery be offered to children with DSD, and are you waiting until the child can decide, or it's family that decide?
We have already spoken about it, but I will be very honest with you. What we were practicing, if it's a 46XX CAH and the parents really want to get the surgery early in our hospital, we used to get the surgery done. But if it's like complete androgen insensitivity and we really want to keep the gonads till the age of 12 years, we used to counsel them that please do not go for the surgery. Or if it's an over testicular DSD, where we are not sure what the child's choice could be, we are not sure about the gender identity, in that case we used to delay. So it's very individualized. Our first choice is to delay the surgery as much as possible, but at some point we need to respect the family decision.
Yeah, I
Okay.
fully agree. Again, I want to emphasize that you cannot change the world in one day. For us,
Yeah,
it took 10
exactly.
years. In other parts of the world, it may take longer because of circumstances. And you cannot expect that it's not a decision, okay, we do surgery immediately or we do surgery when the patient is adult. You cannot change the world in one
Yeah.
day. If you can already postpone in some children the surgery for 3 or 4 years, you will also gain some experience with the other approach. You will be more confident in other parents to even push it a little bit longer and so on. And so this is how you change it very gently and quietly without
Yeah.
losing the confidence of the parents. Because if you lose the confidence, you're lost.
Yeah.
You cannot just do the opposite in one day. It's not possible.
Yeah, I second you. I agree with you. Yeah.
Okay. So I think next question, please, Anissa. So this is from Dr. Rodolfo to Martin. Thank you, Martin, for a very clear and illustrative talk on GC tumor in DSD. I have a question on your introductory point. Can you comment on your experience in ultrasound result in newborns so as to use US at the a first step in the diagnostic algorithm, especially about sensitivity and specificity for identifying Mullerian remnant in the real world, given that ultrasound is highly operator dependent?
Yeah,
Okay.
very, very good, Rodolfo. Very fair point. First of all, you need a radiologist that has some experience with that. And I realize that I'm in a very luxurious position to say this. But I'm sure, Somaya, if you say that you have over 100 cases that are presenting, I'm sure that your radiologist would also have a lot of experience. So I think one of the first things that one needs to do is to ask in your radiology department, for example, that you will only have a limited number of radiologists, 1 or 2, who are building their experience with this. And the more experience you have, the more clear it is. Also, I think what is important, what is helpful, is that you go along with your patient or you call the radiologist to explain the situation, because they see what they expect to see. And if you have, for example, a girl with complete AIS, or you think she has complete AIS, you will get a protocol back with, okay, I have seen the ovaries. And then the radiologist expects to see ovaries. But if you explain that it is, you think the child has complete AIS and that you think there might be testes inside, for example, or you explain that the important thing to know is there a uterus or not, this will already trigger them to look a little bit into more detail or eventually repeat the ultrasound 1 or 2 days later, which can be very helpful.
Okay, thank you so much, Martin. And the next question, please. So this is for Dr. Somaya. How can international collaboration help in providing genetic diagnosis for LIC?
That is a very tricky question, because I think Agustini and Anita, they all know that GPED has been somehow trying to get the genetic testing for DSD and other rare condition in collaboration with other international organization. So honestly, so far, to best of my understanding, I'm not sure about it, that from where we can get the free genetic testing. However, we were getting the genetic testing for the parents who can pay it by different labs, like Centogene is one of them. So, but the parents are paying from their pocket. Maybe Martin can help in that. That Martin, if you do, you know anyone who can provide free genetic access for difficult cases in DSD?
Yeah, of course, I look at it from the other side of the world, literally. And I need to emphasize that also for us, genetic testing is extremely expensive. The cost of a genetic test, especially if you do exome sequencing, it is 300 or 400 euros, which is a huge amount of money also here. For people with a health insurance here, it is reimbursed by the government. But if we accept samples from people, let's say the samples that are sent to us, we don't have this reimbursement. So this costs for us also more than 300 euros per test. We can simply not, we don't have the money for that. We just have money because of reimbursement. So we cannot offer these tests for free. Sometimes we or other groups are have money from a research grant, for example. And if it is a genetic research line, like for example in the Pasteur lab they have some, but also in Australia, the group of Vince Hardy and Andrew Sinclair, they get quite some grants to do genetic research. And then sometimes they within this project, one of the purposes of the project sometimes is to discover new genes, and then they can, with research money, offer these tests. And so this is outside of a clinical context. Then, if you have research money available, and this depends on the timing. Sometimes we also have a genetic project, and we can say, oh yes, please send us samples, DNA samples. We will do exome sequencing. But at other time points, we don't have this money available, this research money, and we cannot pay it from our clinical work because our hospital makes losses like every other hospital. So we cannot do that. It really depends on the circumstances.
Yeah. Thank you, Martin, for the information. Yeah, I think one of the place that we can send for the free genetic testing is in Australia with Kathy Ayers under Drew Sinclair, but it's only for the gonadal dyskinesis, I think. Some DSD that, but not PIES, eyes, and
No.
they need like specific consideration for the patient. So they will check first.
Yes. Yeah. But very often with the testosterone synthesis disorders, you can already expect the diagnosis from the hormone results, or you can do targeted testing based on your hormone results, just like Sanger sequencing, which is cheaper.
Yeah. Thank you so much. And the next question, this is for Dr. Aftab. The only thing I'm missing in advice on how to adjust this protocol to low resources setting. For example, I think karyotyping is needed in all cases. For example, if KUB shows uterus or ovaries in a virilized baby, why can you go directly to CH assessment? Thank you.
Yeah, again, this is a very nice question, but I really feel that karyotyping is a must need for every baby with atypical genitals, because like I'm seeing a huge number of the babies who are basically over testicular DST initially being labeled as a CAH. In our resource limited countries, 17 OHP levels, they are not done in a proper way. They're falsely elevated, and they were being labeled as a CAH because the baby were IUGR because of poor maternal nutrition. They were born preterm. And honestly, for me, though we are diagnosing a CH, but at the same time, we were undiagnosing CH honestly, because we were like, oh, this is not a CH. This is being mislabeled as a CH. Like I shared the case number 2, this girl was having a uterus, the girl was having an ovaries, and there was no karyotype. And then later, the girl was having hypertension, and we came to know, oh, this is a sex chromosomal DST. So I feel karyotyping is needed in all the cases until you are very much sure about. We normally do not do karyotyping if it's a boy having the both testes palpable and 17 OHP is really high, because there's no ambiguity in that case, and we don't go for karyotyping because we know that this is a precocious boy, and that is why. So Honestly, I learned over last 10 to 15 years by having more genetic testing and karyotyping that how much mistakes we had made without karyotypes. That was my learning. Like there was a boy who came to me with simple underrealization, and I thought it's just a hypospadiasis. And when we got a karyotype, the karyotype was XX. He was 46XX male. And because if we don't get in karyotype, I thought it's a simple androgen insensitivity because everything looked like normal. Our hormonal assays are not that much reliable. So even Martin can add on it. I think karyotyping is needed.
Yeah, I agree. Another circumstance where you could consider not to do it, for example, if you have already a sibling with a diagnosed CAH, well, then, of course, in the other one, you probably don't need to do it. But in most situations, I think a karyotype is, if available, it's really the start point. The problem with the hormone testing is not so much that it's not done properly, but there are two ways of doing it. It's with an immunoassay or with LCMS. And with immunoassays, which is the one that is mostly available, the immunoassays just have a lot of cross-reactivity, and you measure all. These tests have been developed for adults with high testosterone levels, for example, but for children with very low levels of testosterone and estradiol, it's just one mix, one big pot with all these steroids, and everything is elevated, of course, but you measure all this at the same time. You measure 17-hydroxyprogesterone, you measure androstenedione, you measure testosterone, it's in a lot of other metabolites. So these tests are just not really made to make a diagnosis of a DSD in a small child.
So, Martin, in your experience, when we have a newborn screening and we already have, for example, for tandem spectrometry for a steroid profile, and we found that this baby have a ambiguous genitalia, but with the newborn screening positive in the confirmatory testing, do you still do karyotyping in your country?
We do in every child, we do karyotyping, and we do genetic confirmation of the type of CAH, for example, 21 hydroxylase deficiency or other. But I think if I would only have the possibility to do a limited number of tests, then I would not do that anymore.
Yeah, because in Indonesia, when now we are starting a newborn screening program, and if we found ambiguous genitalia, but we already have the 17 OHP and other steroid profile that support the diagnosis of CAH, then we did not do karyotyping, because karyotyping is not covered by health insurance. But for the newborn screening until confirmation, it's covered by government.
Yeah. But then, of course, it's important that your full clinical picture is, ticks all the boxes, let's say, and I would certainly confirm with a serum sample with 17 OHP and with androstenedione and so on. And if everything matches, okay, then you can be sure, and the baby gets better when you start hydro and fluter and so on. But in case of doubt, it remains difficult.
Yeah, but not
always be suspicious, let's say.
Yes. Okay, thank you so much. And the next question, I think. This is for Martin. How do you replace with estrogen post-gonadectomy? And do you aim for certain LH, FSH, or estradiol serum level?
Yeah, very, very good question. We have in our country, we have available 17 beta estradiol at all kind of doses. We just ask the pharmacy. We have the pills that are made by the companies in 1 and 2 milligrams of 17 beta estradiol. And we ask the pharmacy to make very small doses in cellulose. Doses of 0.2, 0.3 milligrams. So that's the way we start. We also have patches available, but I never use them for several reasons. You need to cut them, and the child forgets that the patch is on their body, and then they forget to check whether it's still there, and so on. We also have the gels. but they are very, very good, but they cannot be delivered in small doses. And so once you press you push the button, it comes immediately a gel amount of 1 milligram of 17-beta estrogen. So usually I work with separate schedules that are made by the pharmacist. I only check LH, FSH, and estradiol when we are at the end of puberty. Usually I check also the first time when I started to make sure that the pharmacist does not make any mistake, because if the child gets 2 milligram of estradiol instead of 0.2 milligram, then I want to know that. I want to, and so I will see that in the blood. But if I see everything goes well, usually I only check towards the end of puberty, and then I would aim at estradiol levels, which are in the upper half of the reference range for typical females.
Yeah, thank you so much. And the next question. Yeah, this is for Somaya. Please confirm 17 OHP level taken as diagnostic for CAH as case 1 or CAH and 2 both had slightly rise level but different diagnosis. Somaya, I think you are unmuted. Yeah.
So thank you so much for asking this question, because the case 2 was being labeled as CAH in some local hospital by local labs. So that is why their labs were not reliable. So normally we used to take, if the level of 17 OHP more than 300 nanomole per liter, that is somehow diagnostic. It's really high, but still we need to make it sure the baby is not preterm and IUGR, because that is my observation. Even I have seen that high level of 17 OHP in preterm and IUGR, and later they are found to be normal. They were not having any CAH. And similarly, one more thing that I want to emphasize: the carrier of having one gene, they could have raised 17 OHP. They could have slight hyponatremia and hyperkalemia in the first few months of life. Again, this is my experience that when I get the genetic testing done, some of these patients, they were not actually having a CAH. They were just carrier because their sibling was CAH, so the boys were being labeled as that. So in my case 1, we took a level which is actually more than 30 nanogram per deciliter, which is more than 300 nanomole per liter. So that was quite diagnostic. In the case 2, because that was by a local lab, the level was in slightly upper range, but not diagnostic 1. I think they were referring to my presentation, the case 1 and case 2 that I shared.
Yes. Okay, thank you, Somaya. And the next question. It's also for Somaya. Are there any studies showing metabolic, psychological, and social outcome of XXCAH patient who raise as males?
That is a wonderful question. Actually, my department is currently doing a study where we were assessing the metabolic, social, and psychological assessment of all the boys who were raised as XXCH male. Till date, from psychological point of view, because they were presented very late, they are very happy with their current gender of being a male, but they all have metabolic complications like a fatty liver, hypertensions, because most of them were either non-salt loser or they were having 11 beta type. That is why they somehow managed without having a follow-up for like 5 years and 10 years, and they presented so late to us, because if they are salt loser, it's difficult for them to actually reach that level without having a proper follow-up. So they all have metabolic complications because some of them has shifted to dexamethasone or prednisolone by the local doctor. Regarding psychological and social outcome is actually we need to work more, because we are doing a study, and hopefully at the end of this year we will publish the results.
Yeah. Thank you, Somaya. And also in Indonesia, I think we had some publication in the past about the psychological and social outcome of late identified CAH. And recently we also published about the hormonal of the 46XX male CAH. Yeah. With Heidi Klassen from Radboud. And I think for the next question, maybe we still have 6 minutes. Okay. What is the preferable surveillance tool for testicular tumors in adult female with choice, Martin?
Yeah. As I explained to you, that is a difficult thing, especially I think if you're in your settings. I find it already difficult to motivate girls, 16 years old, to come every year for an MRI. So the preferred way of follow-up, I think, well, preferred is a little bit between brackets, because as I told you, it's not fully reliable and it can only detect invasive cancers. The preferred surveillance tool would be one that could detect germ cell neoplasia in situ. But unfortunately, there is nothing that can do that apart from testicular biopsies. But the limitation is, of course, that your biopsy should be taken exactly there where the germ cell neoplasia in situ is, because it's not spread over the whole testis. And so it is a very, very difficult thing. The next best thing we have, I think, is the MRI annually together with the tumor markers. But as I said, they have big limitation that they can only detect invasive tumors. And this is what I explained to the girls who decide to opt to have this. Actually, they all opt to have this, but I don't follow them until they are much older. And they are 17, 18. And of course, they think nothing will happen in life, nothing can happen. They are healthy and feel good, and they don't think about getting sick, for example. I don't know what they decide when they are 25, but MRI and tumor markers each year. But this, of course, an expensive follow-up and a burdensome follow-up. So I don't know if that is really helpful in some settings. I think in settings where this is not possible, the decision is either gonadectomy or have some confidence that overall, if we look at 500, 600 adult women with complete AIS, there is probably only 1% or less who will develop an invasive cancer. So the risk is really very low. But yeah, does that justify a bilateral gonadectomy? It's a personal decision, probably.
Martin, can I ask you something? Like we know that we have limited resources, and we have seen few cases where there's a dysgenetic gonads, and tumor markers always turned out to be negative. Then there was a sudden virilization. I can see that, oh, this patient is getting sudden virilization, and then we took the biopsy, and they were having bilateral gonadoblastoma. So this sudden virilization, is it something to do with the gonadoblastoma? Because
yes, probably. I think some gonadoblastomas can produce hormones. Depends, of course, also on the diagnosis. In the first place, gonadoblastoma will not develop in a patient with testosterone synthesis or action problems. It will be a person with gonadal dysgenesis, so the risk is already higher. And some gonadoblastomas, but I think they might mainly produce estrogens, but I don't think anyone has experience with 50 gonadoblastomas, for example. But I think some of them, depending on the age of this patient, I don't know what age the patients.
He was like 12 years of an age. He presented to us like with a sudden realization. Yeah.
It could also be that this child just started puberty from this dysgenetic testis. If the patient has partial testicular dysgenesis, then there might be also some testosterone production from just this genetic testis, and not specifically from the gonadoblastoma.
Okay, thank you so much. And I think this is next is the last question. Please, Anissa. Yeah, this one is for Dr. Martin. In a nutshell, when not to consider a gonadal biopsy in DSD? Should I rely solely on the gross morphology and location of the gonad?
Yeah, that's difficult to tell you in a nutshell, I think. It depends, as I explained, it depends on the diagnosis. Whether there is gonadal dysgenesis or whether there is testosterone synthesis or action problems, whether the gonad is functional or not, whether it is in the scrotal position or not, at what age the child is. If the child is 1 year of age, I would not do a biopsy. If the child is 20 years, it's not a child anymore, of course, then I would do a biopsy. If it looks macroscopically, depending on if you suspect, for example, that the child is a boy with partial AIS, with an inguinal gonad, which is almost in the scrotal position, and you can easily bring it to the scrotum, and the child is only 1 year old, I would not do a biopsy. If this child would be like 15 years old, for example, the biopsy is more reliable in showing germ cell neoplasia in situ. I would consider it, as I'm just doing at that time, an orchidopexy procedure. So every situation is different. And that's why I invite you to read the paper, for example, the paper that I showed you, but also some others that I've alluded to. They are freely available through PubMed.
Okay, so thank you very much, Professor Kools and Dr. Aftab, for your excellent presentation and for sharing your valuable insight and experience with us today. We have learned about the importance of early recognition of atypical genitalia, practical approach to DSD management in resource-limited setting, and the importance of identifying red flag and assessing malignancy risk. I would also like to thanks to all participants for joining us today and for your active engagement. We hope that the knowledge and discussion from this webinar will support you in your clinical practice and inspire further collaboration in improving DSD care globally. Before we conclude, I would like to invite everyone to join us for the third GPED annual meeting, which be held virtually on 21-22 November and 28-29 November 2026 under the theme Doing More with Less, Managing Pediatric Endocrinology and Diabetes in Challenging Setting. This annual meeting will bring together healthcare professionals, researchers, and advocates from around the world to share experience, innovation, and practical solutions for improving pediatric endocrine and diabetes care, particularly in resource-limited setting. So we also encourage all participants to submit their research abstract for presentation at the meeting. So the abstract submission deadline is 10 August. So we welcome contribution from clinician, researcher, trainee, student working across all areas of pediatric endocrinology and diabetes. Once again, thank you for our speaker, moderator, organizing team, and all participants for making this webinar a success, and we look forward to welcoming you at the third GPED annual meeting. Have a wonderful day and thank you. I send it to Agneta.
Thank you very much, Dr. Agustini. Once again, we extend our warmest round of gratitude and appreciation to all our speakers and moderators. Of course, no event is complete without a photo session, so I invite back Dr. Somaya as well as Dr. Professor Kools to take a group photo together. To all the participants, if you'd like to turn on your videos for a group photo, that would be greatly appreciated. 1, 2, 3. 1, 2, 3. Yeah, next slide. 1, 2, 3. 1, 2, 3. Yes, thank you very much. That concludes the photo session. So to all the participants, please fill in the feedback form as detailed on the slide, and that has been sent via the Zoom and YouTube chat. The certificate of attendance will be shared via email upon completion of the feedback form. As Dr. Agustini has mentioned, we will be having the third annual meeting taking place on the 21st to 22nd and 28th to 29 November 2026 with the theme Doing More with Less, Managing Pediatric Endocrinology and Diabetes in Challenging Settings. So this meeting will feature expert speakers from from around the world, interactive discussions, as well as practical sessions focused on improving care in resource-limited settings. We also have 2 special sessions this year, and we are also introducing a new How to Approach session as well. Registration is now open, and we also offer special group registration rates as detailed on this slide. So we encourage institutions and colleagues to register together. We also warmly invite you to submit your abstracts and share your research, clinical experiences, and innovations with our global community. And we look forward to welcoming you this November. To keep yourself up to date, we urge you to follow GPED on our social media platforms as detailed on this slide. Furthermore, register as well to become a member of GPED via the GPED website as seen on this slide. Once again, warmest round of gratitude to all parties who have made this webinar a great success. Thank you, and we hope to see you at our next webinar. Thank you very much, Professor Cools, Dr. Samaya, and Dr. Agustini. Thank you as well,
Thank
Professor
you.
Thank you
JP.
so much. Thank you,
Bye.
Nitin. Thank you, Somaya. Thank you, JP.
Thank you, JP.
Welcome. Thank you so much. Thank you,
Thank you,
Arneta.
everyone. Yes, thank you,
Bye.
Professor.